Good morning, everybody. First of all, I'd like to say that thank you for everyone for being here today. That last procedure Dr. Palmisani talked about is actually a very interesting one, and we've had some good experience with endoscopic radiofrequencies, in particular for people that have failed conventional radiofrequency. It's really an exciting procedure. So I'm going to talk about percutaneous vertebral augmentation. I have no disclosures. And I was going to go over, because we have kind of a wide variety in the audience, I was going to go over some of the basics of the procedure as well as some interesting fun stuff, hopefully for some later. It was first performed in France in 1984, so it's not really that old of a procedure. 1994, it was brought to the US and used there. And essentially, we've come up with more uses and functions for this procedure and kind of become a little bit better at it. Quickly, the causes of it, osteoporosis, as we all know, trauma, cancers, multiple myeloma, hemangiomas. These down here, the cancers parts, where I think we as pain physicians play a role. One, in helping diagnoses, taking biopsies during these, and also we're going to find later that we do have some more treatment options for patients that do have some of these cancers. Osteoporosis, again, this is just epidemiology stuff. It's 10 million people. Well, these are all U.S. Data. 150,000 hospital visits, and this is where we see quite a bit of this as inpatients. There's a lot of admissions for vertebral compression fractures as well as sacral compression fractures for pain, and many causes. And you could also see that the morbidity, mortality related to it. Once you have a compression fracture, within 5 years, your mortality goes up 40%. So these people, it's a downhill. It can be the start of a downhill spiral. Same numbers as before. And really, what is with these fractures? There's pain, but there's also this cascade of events that we talked about that leads to things that can't be necessarily measured, and that's the quality of life, that mortality, hospitalizations, the dependence. Depression, et cetera, et cetera. Again, brief summary. This is a wedge compression fracture here. T78, TL1, T12L1, most common. 33% of them can have long-term pain. And we still can also have pain. Sometimes even when we do fix these things, there's, with that change in the normal anatomy, there can be extra stress in the facet joints, there can be retropulsion, adjacent fractures, and there's other reasons to have pain in these patients as well. So why do we do this? Because, essentially the non-surgical treatments don't work for everybody. The outcomes can be variable. The immobility from this patient, not being able to get out of bed, not being able to function. You can have a loss of 4 to 10% of your muscle mass per month. There's obviously constant pain. They don't all tolerate opioids. There's plenty of reasons. So our goals with we're going to talk about vertebroplasty and kyphoplasty today. I'm essentially going to use these terms interchangeably because there's only maybe slight instances where really it makes a difference as far as what you're using, which technique you're going to choose. Vertebroplasty is essentially just placing the cement into the vertebral body. The balloon kyphoplasty, we're using a device to create a cavity. And the term kyphoplasty, as far as it's concerned for the U.S. Medicare, which is the body which covers essentially anyone over 65, it's really the creation of a cavity. It's not necessarily using a balloon. So there's different ways to create a cavity. So how does it reduce pain? One, by stabilizing the fracture and preventing that motion, but more importantly, when you inject that cement in there, you're creating this heat and polymerization and essentially destroying these nerve endings. So those are the two that I talked about. I'm also going to briefly mention in the end there metastatic lesions, where we use Kyphoplasty combined with a radiofrequency ablation of the vertebral body as well. Here's an image of a vertebroplasty where you're entering with the trocar, and you have, and you are using a curved tip needle, and you could really specifically deliver the cement polymethyl methacrylate to where you need it. Here's obviously a picture of a balloon, which you're creating the cavity with. What are the indications? Again, every patient, when it comes to treating vertebral compression fractures, that's really where we really need to weigh the risks versus the benefits and determine on a patient-to-patient basis, because these are fractures and they get better. Most of the time if you just leave them alone, but it really depends on what's happening in that in-between time, on their functionality, their quality of life, et cetera. And there are other reasons other than just those osteoporotic fractures we talked about. Where is this? There's a cancer, bad hemangiomas. They need stabilization, and if they really can't do anything at all. And this is what I just talked about. It really depends on the patient themselves and determining based on the MRI whether or not whether you think they're gonna benefit from it. Contraindications, obviously if it's healed, you're not gonna do anything. Asymptomatic, we're gonna find these things all the time. And whether or not it's recent is clearly of importance. Allergy to PMMA. Really the big ones, I think, are if they're on anticoagulation therapy and stopping that if you're able to. And then if they obviously have an infection. Relative contraindications. Retropulsion is something that people will say can be a contraindication, but what you'll find is that most fractures do have some degree of retropulsion. And as long as it's not significant, then there's a good chance that you can still continue with the procedure. Vertebral pars plana or collapse greater than 90%. You can still stabilize that fracture. I did one the other day on a cancer patient, but the reality is if you're losing that much of your vertebral body, there's going to be a big change in the natural anatomy, and there's most likely going to be pain from other places. On tumors, if they're extending into the epidural space. The benefits, stabilization, patient getting better faster, getting up and at them and moving. And you see these as well. And this is something that I think is important, is in doing this procedure is taking a biopsy. This is our opportunity to get in there now early and get a piece of this tissue out and make sure that nothing else is going on. Anecdotally, I don't have evidence on this, on our own procedures. I would say that there's about 15% we find something else. Metastatic disease, multiple myeloma, or different blood dyscrasias, which really don't have that much of relevance. But we find different things, and that's why we take a biopsy in every single case. And it's a good opportunity to catch something earlier. We all know what it looks like. The real question is determining whether or not this fracture is relevant to what's going on, because this is something that can be an asymptomatic old finding. And really, in order to determine that, if you can look at the old films, if they had one recently and it's new, that's one way. Or if you have other imaging techniques, it is much easier to follow that up with an MRI. And if you have an increase in the T2, which would be representative of white. Remember, white is fluid, CSF fluid, fat fluid, and then white in that fractured vertebral body would help indicate that that is an acute or subacute injury. And then also you're making sure nothing else is going on with identifying tumors and whatnot. So after you see this patient, you want to determine whether or not this is a patient. And how you want to approach it. I think with the new equipment we have available, transpedicular approach is really the only approach that I use and that I think is really necessary now that we have curved tip needles and can access. It allows us much better access in reaching really any point of the vertebral body. So transpedicular is my approach, and that I'm going to go over here. Again, performing a bone biopsy, and then having, the ability to have fluoroscopy. When you're doing the procedure, you want to really understand and be able to know what the fracture looks like, so you know how you're going to approach it. Most commonly, we're going to see the wedge compression, so we're going to have to take a cephalad to caudad approach, because if you're going straight in an AP, you're going to end up in the disc or an empty space there. And we're going to go over that here in a little bit. So there's obviously a regular vertebrae. You get the end plates, everything's lined up in the middle there. And then that's a good lateral, and this is what we're going to look at a little bit later as well. We want to have a really good lateral when we're driving this in. So what we're going to see here is now that we have a fracture, what you need to do is you need to pull the pedicle you need to locate the end plates of the fracture and then pull the pedicle between those end plates so you can get your trocar into the vertebral body. So there are end plates. You can see the pedicles right there. We have it pulled in there, and now through this angle, we'll be able to drive it centrally into the body of the vertebrae. So, transpedicular approach, the methods I recommend are kind of dividing this plane into different segments with different lines. And here we have a view of our AP and our lateral. So the first place we're going to use as our landmark and where we're going to enter is marked here, and that's 1. So this represents the outside of the pedicle and the posterior aspect of the column. And when we first put our trocar in there, that's where we want to be. As we tap forward, we want to be mid-pedicular on both planes, and on number 3, we do not want to be past the medial border of the pedicle, because that means that we're not until we are past number 3 or at point 3, because then that means you're going to be inside the pedicle and you're going to be safe from the spinal canal, which is where we can cause some damage. So, and if you look at these numbers and you look where your trocar is, you can three-dimensionally conceptualize where you are, because if you're at 1 here in the AP, but you're at 3 here, what does that mean? That means you're at the bone way out here, and you're never going to get around to the other side. Or if you're at 1 here and you're at 3 here, you're just way too medial, and it's going to be difficult to get anywhere you need to go. And so that's where we want to be there. And so in the axial view, just as I said before, there's 1 and 1. I oblique it slightly when we're doing the procedure. That's where we're going to have it. There's that 2-2 point. And that's where our trocar, this arrow is supposed to represent our trocar. I couldn't get a better image than that last night. And here's number 3, and that's at that posterior border of the pedicle. And then, from there you're safe and you're in. This is just the view of that 1 lateral border. Now here's where mid-pedicular there. And that's that second portion. That's what it would look like in the lateral. Again, make sure that you have everything lined up squarely. We have our end plate here, and you have your foramen lined up, so you know that there's no parallax here, and you're looking at superimposed both pedicles. And then there's 3 about to go in, and then you're in. And at this point, you advance about a third of the way into the vertebral body, and at this point you can take your biopsy. With the biopsy, you kind of screw this device in there, and it advances maybe a centimeter. You aspirate, take it out. You can advance your trocar to the anterior third. At that point, you can insert a balloon or use a curved tip if you have that technology available, because this really allows you, as you can see from here, we're still on the left here, but we're able to advance this all the way to the right side. You can advance it up, down, really any way. And what we're doing here is we're decreasing the need to go bipedicular. Anytime we can decrease an extra stick, an extra puncture, anything like that, you're essentially cutting the risk of the procedure, not in half, but maybe by a third, just from having to not do that, potentially cause things like pedicle fractures or damaging nerves the other way. So I'm a big fan of this. You can use them together as well if there's a need for kyphoplasty. There's that curved tip. This is bipedicular. There's our final view. So when you're injecting cement, again, you start in the anterior third, and really one thing that is important is you really don't need that much cement to have and to decrease the pain. Even this number is big down here. I wouldn't use more than 4 cc's in the lumbar, 2 to 3 cc's in the thoracic. And you're going to inject in the lateral position. Essentially, all of your movements in this procedure are done in the lateral position. And you're going to stop the cement when you hit that posterior third, because that's, once you get past there, you're running the risks, and there's some pretty significant risks if that cement extravasates posteriorly. You're going to inject under live fluoroscopy and go really slow. So there's different methods to get that cement in there. Some of them are pump guns, some of them are turning devices, and some there's trocars that are pre-filled. No matter whatever you use, just you're really going to go slow with that. And then when you're taking your needle out, make sure to put in the stylet, because if you just pull it out, you can get a spindle of cement coming up the spine, and I've seen that happen several times before. The complications for this are low. We do this procedure under essentially local anesthesia, maybe 2 of Versed. I don't know how it is where some of you practice. I mean, and the neurosurgeons in our hospital put these 70, 80-year-old people under general anesthesia. They keep them over, if it's an outpatient, they bring them in, do general anesthesia, keep them overnight in the hospital, which to me is ridiculous, because this can be done with a patient essentially completely awake with some Versed and lidocaine. There are some significant issues that can happen on this side. Pulmonary embolism, again, this is why we're going to do it under live. Extruded cement, bad. And this can happen, and it can happen if you're being as careful as you can. And I'll show you some images of that. And essentially, the procedures, it helps with pain, it gets patients better faster. But if they're not doing bad, these patients can get better on their own, and most of them get better on their own. It's just a matter of, can they tolerate that period for them to get better. Cement embolization we talked about. Complications, we'll just quickly go through some slides. This is, for us as pain guys, something that's very bad if it gets on a nerve root, because you're going to have a horrible radiculopathy that very, very many times it might need to be that cement needs to be surgically excised if it goes foraminally. This guy looks like he used way too much cement here. It can also just go into the epidural space. I've seen this, I've had this happen before, and it just depends if it's going to touch something on whether or not you're going to have pain. There it is epidurally, venous, and then goes into a vein. You can get a pulmonary embolism. It happens. It's documented, and that's something you need to know about. Just moving quick here because we're running really low on time. If it goes into the disc, I personally don't see that much of a problem with it going in the disc, as long as you try to avoid it, because the end plate is gone in these patients, so there's going to be fractures, there's going to be holes, it's going to go in the disc. With a curved tip needle, you can avoid that. That's too much. Again, you got to resist the urge to do this, because you can get adjacent, like when you're putting it in, you just said, wow, I want this whole thing to be black. That's like the natural feeling you get when you're doing this. But the reality is you don't want that because you're just running the risk of potentially increasing adjacent level fractures. You know, I'm just going to go very quickly here. The benefits we talked about, persistent pain afterwards, or pain, like recurrent pain within days. And one of the main issues with this, and one of our jobs is, as the person telling the patient about the procedure and the risk, is that you can have an adjacent level fracture, and it does happen. You know, more with this. And you can see that you know, those risks go up significantly, and I feel that if I didn't tell the patient that and then it happened, they'll say, Doc, like I saw this online, this happens, why didn't you tell me? I wouldn't have done it if I would have got another one. So it's something that you need to explain to them, and it's very important to explain to them because it does happen, and especially they'll be doing well for a couple days, and then they'll have a recurrence of pain or new worse pain after potentially. And then there's the other issues that we talked about from that change in the spinal structure, which is all different things. You can bring them back and maybe do a block or something like that. Very quickly, this is a procedure that excites me a lot. It's a radiofrequency of tumor lesions in the spine combined with a vertebroplasty. And so it's targeted RF ablation with a kyphoplasty, and essentially it's a curved tip needle that can turns into, that is a radiofrequency probe. This for patients with severe pain, single or 1 or 2 level cancers. You can do more, and essentially you can see here. There's just 1 or 2 more slides. Sorry, guys. So here's the levels with the fracture. Whoop. The one down here on the bottom was treated with radiofrequency. Up here it wasn't. You can see the follow-up image 6 months later. You know, these get massively bigger and these still stay small. And again, here's another one. One was radiation therapy alone, and which is that upper one, and the lower one was treated with both. Painful bone mets, here you go. You can see radiation therapy alone, 60% response, combined 93%. Pain relief. Here's the big issue here. These patients are in severe pain, so you can get them better in 3 weeks, as opposed to radiation therapy alone takes up to 9 weeks for you to get some effects of radiation therapy. So patients are suffering while they're waiting. And then the need for recurrent treatment. If anyone has any questions on the New England Journal of Medicine articles about augmentation, we can talk after about it. Essentially, they put out some pretty negative articles a couple of years ago. And so that's really it. Thank you, guys. The procedure works, contrary to some other of those last papers. We have a program with the WIP where you can come visit us at our practice. There's a small donation that goes to the WIP. We're in New York City. And thank you for your time.